Awesome. Well, thanks everybody for joining. We're excited to be with you here today. I want to just real quick do a couple of housekeeping items just as an FYI. I think we still have a couple people joining, and so we're going to get rolling and excited to talk a little about integrated team-based care today. First, just by way of introduction, this is the Iluminate series. SyncTimes has been sponsoring this series. There's a couple upcoming events we want people to be aware of. First up, we have reports training, and so we're helping existing users primarily, but if you're not a user of SyncTimes, you're more than welcome to join. That'll be Wednesday, April 5th at 1 p.m. Mountain Time. Ian Peterson is going to send a couple of things via chat. So if you'd like to register for that, then feel free to register via the link that Ian's sending. Second, we have our next webinar, which will be coming up on Thursday, May 11th at 12 o'clock Mountain Time. And that in that webinar, we're going to be talking with Connexu Community Health about how they've expanded dental services to some of their physical health patients. So how they've utilized SyncTimes to drive increased visits to their dental department from their pediatric physical health patients. And then last but not least, September 28th and 29th of this year is our annual summit that we have coming up. Last year was our first annual summit. I think, Diana, you can give the review here. I think it was a raging success, and we're pretty excited for the next one.
Definitely, Alan. For those who can attend, I highly recommend. It was a great event, great networking, and it was very fun.
Yeah, awesome. Well, thanks, Diana. We're going to move forward here. You'll see a bunch of things coming through in the chat. Just by way of housekeeping as well, the Q&A is active, so if you have any questions, feel free to use that functionality. I know we've got the chat going. We also are going to be using a poll that we'll deploy here in a couple of slides, so just keep an eye posted for that poll coming available. By way of introductions, we talked a little bit just on the chat there about where people are coming from. My name's Alan. I grew up in Eastern Washington, live in Utah now. So I'm not sure if you can see behind me, there's some kind of cloudy and snowy mountains behind me today. Big fan of the mountains and good to be here. I was in Arizona earlier this week, where Diana is joining us from. Diana, it looks like that must be sun behind you. Is that right?
It is. We finally have some sun. We've had rain for 2 days, which is not very common for Arizona.
Yeah, I think we've had rain and snow here for about 6 months, so I'm a little jealous still, but yeah, that's great. I'm going to introduce Diana. So I serve as CEO of SyncTimes. I'll give a quick intro to just SyncTimes and what it is for context. But before I do that, I need to introduce Diana a little bit. I always try to embarrass my guests slightly, and so sorry, Diana. Hopefully that warning came ahead of time. By way of introduction, Diana was recently promoted to be the Training and Compliance Director at Adelante Healthcare, where she has provided dedicated service. As of January, she had her sweet 16th anniversary there at Adelante. So 16 years at Adelante. That's right, isn't it, Diana?
Yes, that is correct.
Awesome. Remind me where you're at today. Which side are you at today?
I am actually based out of the corporate office, so that's my new home.
Awesome. In her time with Adelante, Diana's held various titles and roles, both related to patient care as well as outreach. Most recently, she's focused on helping develop and implement integrated care team models across the multiple locations for Adelante. She's primarily focused on evaluating and providing needed services to meet patient needs, improve health outcomes, and importantly, helping to improve the community through effective prevention and education. Diana has been awesome to work with. Remind me your title as of a year ago, Diana.
Definitely. When we started partnering up with SyncTime, I was the area operation manager for Adelante Healthcare, which I oversaw 4 of our locations, including comprehensive sites.
Awesome. One of the challenges that I have is that our excellent people in operations often get promoted, and that was the case with Diana. And so we miss having her full-time in operations, but she's doing great work there in training and compliance as well. So thank you so much, Diana. Great to have here. I mentioned I was going to introduce you. I hope or embarrass you. I hope you didn't think that already happened. So this is just a fun, fun photo here. I'm also going to introduce John Boyd and embarrass him a little bit. He's on our team. He's here, and then we've got Diana, Bianca, and Dr. Babiar from the Adelante team. So good to have a fun picture. I'm trying to remember. This was an event that you guys were all golfing at, right?
Yes, definitely. This is one of our annual fundraisers, golf tournament, and we've done this tournament for many years now.
Yep. So I've been permanently scarred by seeing John in a tutu here. I just wanted to make sure there's some other people suffering with me. So awesome. Just real quick, by way of introduction, I just wanted to give kind of some context as far as what SyncTimes is and kind of what the system looks like. Hopefully this will just help as we dig in and talk about Adelante's workflows and what they've done with this data and with this system, really just to have a better feel for the context as far as what we're looking at. So we've worked pretty exclusively with community health centers for the last 5 years. We provide a system that includes tablets, both outside and inside of exam rooms, and then television displays that we call flow stations. These are placed in central team areas or in pods, and they show what's going on in each room. Here you're seeing some of those tablets outside of the rooms. There's one inside the room. Those are used for communication. So each of these icons communicates something that's needed for the patient. There's also a real-time locating component. So staff wear a beacon that shows where staff are throughout the clinic. There's a lot of data that we're capturing with that around productivity, who's visiting patients, how long they're spending with patients, how long different needs are taking. And so you're going to see a lot of data throughout this webinar. And the hope is that this just gives you some context as to how we are gathering that information. This morning, I just grabbed some really basic data from one of Adelante's flow station views. And so just to give you an idea of some of the things that they're using this for, here we just have 2 patients that are in exam rooms right now, one in F6 and one in PEDS 3. In PEDS 3, there's 2 medical assistants that are with this patient doing intake. In F6, we have a provider that's in the room. Patient's been in for 43 minutes. The provider's been in for 3 minutes. They have a timer for 3 minutes, and then this is saying this patient needs blood pressure recheck. So this is just an example from this morning of kind of how they're utilizing the system. These are the icons that they're using at Adelante. And so just showing this to give an example, and we're going to talk really a lot today about some of these workflows that they're doing and how they're measuring the utilization of dietitians, behavioral health coordinators, behavioral health consultants, health educators, and so on. So with that kind of background on SyncTimes, I want to turn the time over to Diana. Hopefully you can, I haven't embarrassed you too much. I'm sure there's more, you probably have more ammo on me than I have on you. I just had a fun, cute picture. So I'll turn that to you, Diana.
Thank you very much, Alan. And yes, it's a little embarrassing, but it's fun. That really does reflect the partnership that we all have and how easy it is to work with you and your team. So I really appreciate that. So thank you for that. Well, hello, everyone. Just want to talk a little bit about our organization. Adelante is an FQHC that we are based in Arizona. All of our clinics are in the Maricopa County. Currently, you see on the screen a few of our locations. We have 9 locations, and those locations vary services based on the population. We do have some very rural locations that house maybe one provider that is very remote from hospitals and pharmacies, and other locations that are really centered around all services. So our newest location that we opened last year houses multiple specialties from dental, behavioral health, family practice, IM, Care Today, which is what we call our same day center, and different services. Currently, we serve about 85,000 patients. What's been very unique about Adelante is this growth has happened drastically. In the last 4 years, we've almost doubled our patients. And as many of you have probably faced the same challenges we do during COVID, instead of releasing staff or having to cut some services, we actually added over 300, about 250-ish employees because of our rapid growth. Currently, we continue to grow. We are actually looking at having one of our smaller locations be turned into another comprehensive center. So that's just a little bit about who we are and what we do. All righty. So with SyncTime, when SyncTime was first introduced to me, it was more in a sense of understanding our cycle times, really understanding what our patient alone time was. When we started looking at the opportunity with SyncTime, this is where I challenged Alan a little bit. I said, hey, I think I want to look at this at a different opportunity. And some of the goals that we decided to look at was really how do we optimize the use of an integrated care team, as well as how can I evaluate the staff ratios based on the utilization. During this time, we were still within COVID. So we were really trying to identify like how can we maximize the employees, retain them, and maybe shift things around that makes more sense for the organization. What I want to kind of review, and this is more of my personal experience and recommendation if you haven't implemented or you're looking at implementing SyncTime. When we first started rolling out this program, we looked to every support that we can get. We had a very comprehensive team in our implementation project, which included buy-in from our chiefs, our IT support team, our integrated care teams, management. We had provider champions, medical assistant champions, even our facilities, because it does impact in the implementation. Because they do have to help with installment and coordinate with the electrical pieces. But this type of implementation, I feel, was very successful because having the right team, the core team available, we were able to make decisions much quicker. We were able to meet our timelines and really focus on the support that we needed. So my recommendation to you would really be to look at who your implementation team is and who are the key stakeholders to help you move this process along and have the right knowledge in place. Because as an area manager, I am not familiar with some of the IT components or even the facilities, but having those key resources for me there, I was able to ask questions. Alan and Ian were able to connect with those individuals directly. So that really did help our process. Over time, you can shift your implementation team, but recommendation is early on, get the right people involved.
I want to real quick, Diana, would you mind just kind of introducing the whole AIMS initiative and kind of how that factored into this implementation team and then the people that are involved in this?
Yeah, so AIMS first is kind of an organizational approach of how we look at infrastructure, improving our organization as a whole. From the AIMS model, we have an umbrella or a piece of it that we call the integrated care team model. Some of you may be familiar with it, formerly known as a PCMH group, but really the integrated care model was really focused around having the patient be the center, bringing those needed services to the patient during their visit, really able to identify their needs, their barriers to care, and having a core team help address these issues while the patient is in the office.
Awesome.
So I'm going to go through a little bit with our discovery process. As I mentioned early, we started looking at our objectives. Like most other organizations, we did want to understand our cycle times for our patient and the support team process improvement. Currently, we did not have a process that would help us with that information. And if I really wanted to identify a cycle time, I had to do more of manual work. So SyncTime did provide that information in regards to breaking down where is the MA at, where is the provider, how long is the patient cycle. So that information was very helpful. But in the observation, as I mentioned earlier, we looked at the process and we really thought about how can we maximize this tool for the benefit of our providers, our teams, and our patient? And this is quickly where we identified those opportunities and new objectives. We wanted to test SyncTime data to see how it can help us optimize the integration in our clinics and change the structure of our team. So what you see here is really kind of that cycle of what we did as a team. We were in the observation, we asked the questions, we started researching the topic, looking at the data, coming up with the hypothesis, what will this do for us? Once we implemented some of those, we started to analyze some of the additional data, and then from there we were able to conclude and report on our improvements with the shift in the objectives.
Awesome. And I think this next slide is really talking about that research. Is that right, Diana?
Absolutely. So in this case, we really looked at the patient flow. As you guys have seen, really our wait time is in that red area. We knew that we were not able to shift a lot of that alone time. An average provider would go into the exam room, go into the next room. The patient was waiting on average about 30 minutes. What we decided is to really focus and evaluate the alone time. We identified again that most of that alone time was after the medical assistant did the intake and while the provider came back into the exam room. So we did identify that that's where the patient was feeling, maybe left alone, forgotten, maybe there was no updates for the patient, which often, that perception from the patient is, oh, they forgot about me. So in this, we utilize this data really to empower the teams to identify the best opportunity to see a patient. What I mean by identify the best opportunity is, and we're going to go into another slide, really maximizing our care teams of doing some early interventions during that alone time. With this data, also, we were able to utilize it to improve our huddles, which did improve the outcomes of care. I know for our organization, we were struggling with some of the huddles, but with this data, it was more transparent, as Alan mentioned and showed in one of the pictures. It is very visible with the screens and really easy to identify where is the patient, what will the patient need. So that really drove a lot of our huddles.
Yeah, I think I want to just kind of break this down a little bit. What this is showing is kind of during this initial research process, part of the question that was asked was, hey, what we're seeing here is patients are spending between 14 and 12 minutes alone waiting in the lobby. So before they come to the exam room, once they're in the exam room, in total, they're between 27 and 31 minutes alone, between 8 and 12 minutes with staff, and then around 15 minutes with their provider. So a couple of things that this means, when I just look at this quickly is our patients are coming into the clinic, and in that time, they have about 23 minutes in the exam room where they're receiving value. And in exchange for that time, there's between, call it 40 and 50 minutes where they're waiting or they're alone. And so the question was, how do we take that, wasted time? How do we take waste and use it to drive value? And I think what Adelante did a really good job at was they really married that to their AIMS initiative to say, okay, we have an opportunity here. Let's take that time. And rather than just, sometimes I think there's a tendency to say, let's just crack the whip over the medical providers. Let's just try to get them to work faster or more efficiently. Instead, it was, let's support our medical providers with some services that they really need for their patients. And so I'll shut up here and jump to the next one here. But that's really the conversations that we were having early on. And there was a lot of, I think this data really brought to light that there's a lot of opportunity here. There's a lot of opportunity with how we are using our patients' time.
And Alan, you brought up a great point, which, we weren't covering it in this training, but when we focused on the provider and meeting some of their needs, it really improved satisfaction and them not feeling as pressured because they had additional support in spending time in the education piece and really just focusing on the patient care and not necessarily on other items that other care teams could support with. So I thought that was very valuable to hear the feedback from the providers that this process did help them feel more supported.
Mm-hmm. Awesome.
So what I want to cover here a little bit is really first, I want to go over our integrated care team because some of you, again, are familiar with this. Others may be newer to this. But what we define as a care team is not just the provider and the medical assistants, but other individuals in the facility that can assist with other duties. So for example, we have a registered dietitian that could really focus around patient education, specifically around our diabetics, our hypertensives, what is the right food for them to eat and giving them that nutrition assistance in-house. We have a registered nurse and a care team, which they really focus around other care needs for the patient. Like maybe it's them helping them with the medication reconciliation, identifying did the patient take the medication, and if not, what was the reason? Maybe they had trouble getting it through the pharmacy. Most often, our population, we're very heavy with Spanish-speaking patients, and sometimes the patient does not understand, how to take their appropriate medication. We have health coaches, which we transitioned the name to care coordinators, which I'll go a little bit more into detail in a further slide, but that's one of the shifts that we were able to do. With the health coach, they were focusing on some education as well, which kind of interfered with some of the registered dietitian. So we shifted their title, their role, and really the care coordinator focused on helping us close care gaps like stat referrals, maybe the patient hasn't received their eye exam. So they really help coordinate those additional visits for the patients that are external from our locations. Our behavioral health tech and behavioral health coordinator are two different levels of behavioral health intervention. One of them focuses really on quick intervention, just making sure everything is okay, looking at the PHQ-9s, universal screenings, and then if they identify that additional services are needed, then they connect them to our therapist. So the behavioral health tech and coordinator work hand in hand. One of them spends more detailed education. One of them is a quick assessment and intervention.
Awesome. Real quick, I have a couple questions. I want to just stop on this slide for a second. While we're doing that, we have a poll that we're going to deploy. We just want to kind of understand from the audience here a little better what you guys are doing in these arenas, and kind of what of this is more or less applicable, or maybe more or less overlap with this fairly broad team that Adelante has implemented. Diana, I just kind of want to talk a little bit about if you could just share kind of an example of how, just using a diabetic patient as an example, what that would look like in this model. And then also I want to talk a little bit about kind of the traditional model, which I think really dumps a lot of the burden for a patient like that just directly onto the back of the medical provider. Would you mind kind of just walking through that a little bit? I think that could be helpful.
Absolutely. First, with our population, our patients have many struggles to barrier to care. That can mean transportation, that can mean lack of resources, taking time away from their job, taking time away from taking care of loved ones. So the focus with these two integrated care teams in SyncTime was really to maximize the patient's time and appointment. So if I look at the diabetic, for example, when the patient comes in and they do their intake and they're waiting for the provider, that's where we use the care coordinators to really look at what referrals are outstanding, close those gaps, like retinal eye exams. We looked at the registered dietitian, giving them some education on healthy eating. We looked at the nurses, again, as I mentioned earlier, looking at the medication reconciliation, going over how do I give myself the insulin, how do I do my glucose check. Behavioral health tech coordinator would come in to identify, maybe this patient is experiencing grief, maybe they have depression because of the diabetes. Maybe the diabetes is causing them to feel tired and not be able to be very active. So these are where the coaches come in and really help assess the patient needs, which in return really maximizes the patient's appointment time. And when you look at it as a financial, it also maximizes your return on investment, because now you've done not only the medical visit, but you've done other intervention visits, which I believe we also have in another slide, but it really almost gives you 3 encounters, billable encounters per patient. And most important to what you said earlier, Alan, it's the provider doesn't have to spend the extra time having to do these educations, going over these items that other individuals can support, which then allows the provider to move over to the next patient and really focus on the care needs for that individual.
Awesome. That's great. And we'll probably come back to the poll. Let people keep filling that out. Looks like we're getting submissions as we go. This next slide, I want to give a little bit of context here just for everybody's information. This is one of the reports in SyncTimes. This is basically showing a timeline for a specific patient. And so looking in red here, this is the time that this patient was in the room. Anyone in green is a staff member, and then anyone in blue is considered a provider. And so, Diane, if you want to just kind of walk us through what this visit looks like, and this was just an example that was brought up by a clinic manager during one of our calls. The question was, well, are we actually doing it? Are we really doing this AIMS initiative that we have? And the clinic manager was able to quickly pull up this report and show, okay, this was a patient that we saw yesterday, and this is what their experience looks like. Diana, do you want to kind of run through this for us?
Yeah, absolutely. And, I want to mention to that, Alan, it's that utilization of the data is very important for our managers, for them being engaged in how to utilize this data, how to identify it. As an area manager, I was very impressed that this manager could quickly pull this information. That showed me that they were engaged in really understanding the data. But going over this particular example, this is a great example of what intervention looks like. And when you really look at the whole process, this patient did not spend more than maybe 10 minutes alone at any time. It started off with the medical assistant really doing that intake process, which you will see there in that first brown area. Then it went over into our BHCs. This is where they were focusing on doing some of the screenings, universal screenings, are identifying barriers to care. Which the next piece of it allowed for a medical student to come in and help address patient needs. And really, that's our way also of supporting education with new coming providers. The next blue area, which you see toward the middle of the screen, that's when the provider came in to address the patient care needs, followed by really looking at the RN, which is in the green, giving that additional support. So I think this is a great example, because if I did not have those integrated care team support, the provider would have probably been doing all of this additional intervention and or education, which then slows down, our intake for the other patients, and really boggles down the system. It holds down exam rooms. But with this perfect example, and I call it perfect because we really maximize the appointment time, and at the end of the day, the patient was not left alone for a long period of time.
Mm-hmm. Yeah, that's great. I think just a couple of things to highlight here. One is, in total, this patient did spend, about 25 minutes alone, but that's broken up. That's in the aggregate. And the reality is that, the longest time was maybe 5 minutes here. But for most of this visit, this patient was with somebody and receiving kind of a different core piece of care from each of these individuals. And just walk me through the roles of these people. I'm assuming we've got our medical assistant, and then kind of walk me through who all this patient saw.
Yeah, definitely. In this visit, we had the medical assistant, which is more on the brown area. That's the individual who's really greeting the patient, doing the intake, the initial. For us, we have a lot of standing orders, so they're the ones initiating all of those A1Cs, prior pregnancy tests, anything that could be considered a standing order. And then, as I mentioned, the next area really was around the green. That was our BH team, and that was just the early intervention pieces, really just identifying quick assessments. The blue areas, as we mentioned, they're providers. The first blue was really the student provider. And then the second blue area was our actual doctor in office. And the last green area was really the registered nurse.
Awesome. Yeah, I think a couple of just thoughts. I want to share a couple of thoughts I have, and then also ask you, Diana. But when I look at this, my immediate thought, and I think a lot of people with operations backgrounds, you look at a visit, and historically, what you kind of have is just maybe the overall cycle time. Maybe what you're looking at is saying, okay, this was an hour. Call this an hour and 10 minutes, an hour 20-minute total visit, right? And the immediate response might be, well, an hour 20, maybe that's not a great use of the patient's time. But when you're able to really like dig in on the data and you're able to actually see like these are the people this patient saw, this is really 3 appointments that this patient's had. And what that means is that rather than having to get a babysitter 3 times and leave work and ask for time off 3 times, this patient was able to come into the clinic once and receive, all that care in one exam room. There's waste that we have in our system around having to turn over exam rooms for those extra visits. There's some inefficiencies around having to check in a patient for multiple visits, your no-show rates, having to worry about a patient not showing up potentially for 3 appointments instead of 1. So, when I look at this, what I really see is there's a tremendous amount of value that's being provided for this patient in that, that time block. It might be a little longer than an average visit, but it's a hugely valuable experience for that patient, as well as for the staff, the provider who doesn't have to go through everything that, the other people in the clinic were able to visit with that patient. I want to pass that to you. When you think about this, just from terms of patient experience and value, what are your thoughts, Diana?
Definitely. And one of the things I can share with this team is we actually did some surveys for our patients during these process, and we received some very positive comments from them. One of them, a quote from a patient was really, I felt cared for. One of them said, I even got to see a registered dietitian. So that demonstrated to us that it did give value to the patient. The perception they were seeing was I was cared for. They really are invested in me. So we were really happy to correlate that with our survey, and that also helped motivate our team and providers. They, felt a sense of accomplishment of the patient really values us and really values the care that we give for them.
Awesome. I'm going to jump forward a little bit here. We've talked a lot about just kind of adding that. I want to talk a little bit about some of the transitions you guys have made as far as integrated teams and how you've adjusted your staffing model there.
Definitely. And I think I mentioned it a little bit earlier in the slide where we were talking about what is our integrated care team. But through this assessment, we were able to identify what each individual's role is within the facility and how we can shift those roles to maximize our staffing. One of the pieces we really focused and changed was removing the health educator and really transitioning them into a care coordinator. This allowed for the care coordinator to really help us close those care gaps, which in return did help us improve our UDS measures, specifically around A1C and our blood pressure. I know, Alan, you showed an icon where it had the little blood pressure reading. One of the struggles that we had was when the patient came into the office and had that elevated blood pressure, us doing a repeat, 10 minutes after they settled down, which often, provided a better blood pressure reading because the patient is now, settled in, relaxed. So that care coordinator really helped us to identify those gaps and help close those pieces. In addition, with that transition, they were able to help us close out really those stat referrals. We identified that, with staffing needs medical assistance focusing on that patient care, those standing orders, there was times that, maybe a patient didn't get that stat referral immediately. So the care coordinators were able to really focus on prepping, getting that referral done while the patient was in the office, which then in return, it maximized the utilization of our RNs and RDs to really focus more on targeted education and really diving down more into the details as to where the health educators before were very limited on what information based on their credentialing of what they can educate a patient on.
Awesome. Jump forward here. Going to get to a little bit more data and results here.
Perfect. So this example here, what I want to share with you guys, in May, when we first started this project, if you look at our numbers, our utilization for a registered dietitian was really 0 for the month. The RN was 15 and the BH was about 44. When I look at that in the operations pieces, I have a registered dietitian that is not being utilized, and it can potentially, affect your financial budget. But in addition, you have a resource there that is very valuable, and we were not utilizing it. So with the shift that we did based on the data that SyncTime did provide in September, when we reevaluated some of these pieces, you can almost see that our integrated encounters tripled. Our registered dietitian was able to serve more patients, as well as our RN. And our behavioral health team, as you can see, went up to 108. For me, that BHT one is very important because that was a drive from the huddle. Often I was hearing from our teams that our providers maybe didn't know when to call the behavioral health coordinator text. The behavioral health team maybe didn't feel comfortable in coming into those exam rooms during that wait time. So by educating them on the resources, the data, using the icons, this improved our outcomes with the number of patients they served.
Awesome. One of the just pieces I want to highlight on this slide that maybe goes without saying, but that we've observed is that oftentimes one of the challenges with integrated models is that the medical providers are fairly they want to protect their exam rooms. They don't want their exam rooms to be used by others. And often the concern is, hey, I don't want a behavioral health consultant coming in here and spending 30 minutes, occupying my room, talking to my patient, making me behind. And so that's important. And it's also a piece of data that we're capturing here and looking at, on average, how long are these patients spending with integrated team members? And you can see it's really not all that long. Some of this is that the registered dietitian, you're kind of seeing a trend downward. But, if you just say it's on average between 8 and 12 minutes, it's not long when you consider that what we see in the aggregate is that patients are usually spending 18 to 22 minutes alone in the exam room for any health center, really. And so when you look at that and you see, man, there's just an opportunity here, and it's actually not that big of a burden on the exam room. There's a lot of opportunity there, but sometimes what it does take is showing the medical providers, here's the actual data in your practice. This is how long your behavioral health consultant is actually spending with patients.
And Alan, that is so true. We did experience that early hesitation, but again, with that data being very transparent to the whole team, we were able to demonstrate that. And at the same time, that's what made the providers feel more comfortable in the sense of like, oh, well, I have time to do what I need to. I don't need to feel rushed, and I'm not worried about my exam rooms because it was very clear and transparent to them what time we were utilizing to educate these patients.
Awesome. I'm going to jump forward here a couple more slides, and I think there's a question that came up that we've got a slide for, and it'll be the next one, I think.
Perfect. Here, you just see some general information about some results. So when we really started looking at this, you can see kind of our alone time fluctuating. January's data here shows that it's the alone time is trending down, but even though that it's trending down, we still have not slowed down our integrated process and really those integrated visits.
Yeah, and really the background on this is that rather than spending time alone, patients are getting time with an integrated team member.
Mm-hmm. What I want to point out in this slide here is really when we first started that initial May, on average, 1 of 10 patients were getting some form of integrated care support. Where we're at now, we're about 1 in 3 patients get this additional support and care.
Awesome. So this is basically the percentage of appointments where they had a medical appointment, and it was around kind of 10%. And then that's gone up to roughly 30 to 33. So what was maybe 1 in 10 patients having an integrated team visit, that's now about 1 in 3 is what we're averaging. Yeah. Want to just real quick, there was a question around financial incentives and kind of the compensation model. Arizona is different in this way, and I think it depends a lot on the state. There are states where you can't bill multiple encounters in the same day, so recognizing that's the case. But Diana, just as far as for you, do you want to just talk a little bit about kind of the financial incentives and how you guys think about those integrated visits?
Definitely. So currently with our organization, we don't have an incentive program for across the board. Our providers are on an incentive program where if they see X amount of visits beyond their contract, they do get incentives. So with this integrated care model, they were able to see one or two additional patients a day, which did increase their incentives at the end of the month. For our medical assistants, we're utilizing some of this information as we start looking at that value-based care and really how we can improve those results, which then the plan is to do incentives for our additional support teams because we know that they do play a big part in this, but we're not quite there yet right now with the value-based.
Awesome. And then this, looking at this slide, this is based on a fairly small 2 to 3 provider practice. So this is a small practice that we're looking at, fairly significant on the revenue side. I'm going to talk just a little bit. Next steps. I know this is something that's kind of a work in progress, and then we'll get to Q&A here. There's been a lot of questions, a lot of interaction on that side.
Perfect. Yeah. So, in conclusion, we were able to again evaluate those two areas, right? What is the medical assistant time? Often, for those who are in operations, we identify that some medical assistants are more efficient, some of them may not be as much. So this was able to help us identify that piece of it. We were able to utilize the utilization of the care coordinators. With this, we were able to realign responsibilities between medical assistants and care coordinators. MAs were focused more on direct patient care, and the care coordinators were focused more on that care gaps, which kind of includes like the chart prep and really getting those additional documents, which then allowed the medical assistant not to forget those standing orders like A1C, which is a big drive for our diabetic patients. With this, we were able to realign our structure. So here's just a general example of a practice of 4 providers. We were able to bring them down to 6 medical assistants and 1 or 2 care coordinators, depending on the specialty that would really focus on those care gaps.
Awesome. Yeah, and I think one of the pieces here to just look at is really what you've done is you haven't added, a whole bunch of FTEs. It's really been an adjustment here, right? And going from a 2 MA per provider model to kind of a 1.5 with half of a care coordinator available per provider. Awesome. I'm going to jump to conclusion, and then I'm gonna be peppering you with questions. There's been lots of questions coming
No,
in, Diana.
definitely,
So I
definitely
hope
anywhere
you're
that
on
I
your
can.
toes.
I'm ready for this, guys.
Okay.
So in conclusion, with SyncTime data, it really helped Adelante to illuminate the areas of opportunity to assist us in providing that great patient experience and helping us really improving those health outcomes for our patients. In this phase, we focused again on the optimization of our integrated team and evaluating those ratios based on the utilization. I would not be able to do that really without this data, which made it very transparent and very visible to our teams. For us, this is just the starting point in the discovery process. We look forward to continuing to illuminate new opportunities and changes in the way that we do deliver this comprehensive care for our patients.
Awesome. Well, I'm gonna just jump in here with questions. There's been a bunch here, and we're about 42 minutes into the hour, so I don't want to, and so I want to make sure that we wrap up before the hour. So, Diana, the first question that I've got noted, and Ian, if you'll just help me if I missed any. I tried to write these down as they were coming in, but I may have missed some. So, first one was just a question about how do you align the provider incentives with value-based care? So thinking about your medical providers, how do you align their incentives in this environment that you're working in?
So I think I kind of mentioned it for us, value-based incentives were not there yet. That's something that we are actually almost like the second phase of SyncTime process with us too, right? We're looking at how we can maximize and illuminate the data and look at our like our Medicare wellness visits. How can we restructure and use some of the RNs to really support with those functions? But in that process is where we're looking at how we're going to distribute incentives for our staff, for our providers, and really aligning it them to the health outcomes of the patient. But in short answer, we're still in working process with the incentive piece.
Awesome. Want to ask a little bit about the huddles. There are a couple of questions that came in about the huddles, and I think that maybe if I were to break them down into two sections, one of them is just around like what was actually being discussed, what data was being used during. Do you guys use during your huddles? And then the second is maybe just functionally, how do you make all that work? How do you make the huddles work? I think a lot of health centers that we work with,
Mhm.
in theory, they want to say, yeah, we're doing huddles. In practice, maybe that's not actually happening as much as we'd like to think.
And definitely, we faced all of those same challenges. So, I'll talk a little bit about first what we discussed within the huddle. So, different organizations have different processes. We have a platform called Azara, which Azara really identifies the care needs for the patient. If they have gaps that need to be closed, like referrals, orders, vaccinations. So, really assessing what are those things that the patient might need. In addition, that's the great opportunity also for the care teams. We don't just align it to the doctor or provider, make a decision of the BH needs to be called in or the RN. We use that information to empower the whole team to say, hey, the registered dietitian might say, you know what, this is a diabetic patient, I really need to go and see them. So that's where they use the huddle time to be able to quickly identify who needs to be seen by whom and what we want to focus on. Being realistic, we know that it's not always done because of time restraints. But by making this information very transparent again and being able to allow each team member to feel empowered to say, hey, I need to see this patient, really helped our adherence to huddle. When SyncTime first came in, I was struggling with this team with huddles because, in a sense, there was no ownership, right? The BHTs or RN were telling us, well, the provider, the doctor is not calling me to come and see these patients. Well, I don't know where the patient is at now because our system doesn't do it's a manual update to identify where the patient, what exam room they're in. But if there is any like movement of that patient, the RN care teams did not know where that patient was at. So we really struggled where, in a sense, they first gave up on the huddles. They were not happening. We noticed that there was lack of teamwork and no participation across the board. But when we started to really use SyncTime, the data, the icons, that shifted our culture because, again, we were able to be, when we had our team meetings, we were able to share that, hey, overall, the RNs, you only came into the exam rooms, maybe 5 times in a whole week. What's happening? How can we help you? And that's where we really focus on that empowerment of identifying which patients they also wanted to see. So it really helped us in improving. And from there, when we did our next evaluation, our huddles were, pretty much happening every day consistently.
Awesome.
Related to
There was a
that.
question that your neighbor down there, Bria, with Sun Life had asked, and I think it kind of ties into the huddles, but just functionally, who is flagging, in the visit, and what does that look like as far as icons? So when are they adding the icons to say we're going to need this person? How do you decide kind of who's going in first? What does that look like, and how are your integrated team members responding?
So one of the pieces, again, it's hard if I come in as an operation leader and say, hey, do it this way. So instead, we allowed them to make those decisions as a team and identify, again, empowering them that they all can call for these services. But they created a more of a team's chat to say, hey, I'm ready for this patient. And they really enhanced their communication. I know that it's not feasible at every department or every location to use Teams, but what we've been able to replicate with this pilot within Peoria, which is our site that we were looking at this, it helped others, right? Really aligning them to identify and really manage that patient time. So instead of me telling them how to do it, they came up with their best process, which then improved that collaboration and teamwork.
Awesome. There were kind of three questions related to services on site. One asking, do you have imaging on site? Another one asking about HbA1c machines in the clinic. So maybe you want to address those. Related to those, there's a question just around, will slides be available and recording? We're going to upload a recording of this and then we will send that out to anybody who's registered. If you're on the meeting now, you've registered, so you'll get a recording as well as the slides, roughly in the next 24 to 48 hours. But back to that question, Diana, just around imaging on site and HbA1c, I think those are the main ones.
Yeah, definitely. For X-rays, we do not have that as one of our service items. The only X-ray imaging we do is within our dental, but no, we don't have those services.
Okay, great. Let's see. Got one other question here is what type of student providers do you utilize? And then what information, what are the students doing during that visit? What information are they collecting, and how does that program work?
Absolutely. So we focus around, we have partnerships with different schools. So when they are doing their rotations, we partner up across all of our locations to welcome these students. And really what they focus on is they go into the exam room prior to the doctor, and they start with the basic questions, welcoming them. What are you here for? Really getting that assessment piece of it. And then when they exit the room, they're kind of giving just a recap to the doctor. And I'm sorry, I keep calling providers because that's how we refer to all of our nurse practitioners mid-levels too. But the student doctor comes in and really does that recap with our providers, which then the provider just goes back into the exam room to validate some of that information and really then discuss the plan of action for the patient. But this is really just allowing the student to do real-time practice and really put their skills to use and have that experience.
Awesome. Question around, do you have social work students?
And no social work students.
Okay, cool. One of the questions is just, I think it's around the responsibilities of the care coordinators. Are they helping with scheduling with specialists, with referrals, or what would you say kind of falls under the umbrella of your care coordinator responsibilities?
Absolutely. So the care coordinator does focus a lot on the scheduling the appointments with the specialist and more around the stats, right? Because for our regular referrals, we do have a referral department, but the care coordinator really focuses on the patient that's there right now. Often, we may have a referral that our referral department may not have already completed. So that's what they focus on. They look at opportunities to help the patient with coordinating transportation for their specialist appointment, and really focusing on what outstanding items is there on the patient's care plans that they have not completed, and really help coordinate those future appointments internally, externally. They focus, again, as I mentioned earlier, a lot on the care gaps. So if they identify that, maybe this patient hasn't had a A1C, they make sure that the MAs, don't forget about that and really highlight it. So in a sense, they really help us a lot with the administrative pieces that sometimes our medical assistants get stuck with, and prevents them from bringing the next patient back. I don't know how many of you have experienced, but me, even as a formal medical assistant, I remember spending, 30 minutes trying to get through a specialist and getting that coordinated. So now having somebody dedicated to really help with that allows our medical assistants to focus again more directly on the patient's needs at that moment.
Awesome. One question, I think we're going to make this probably last question here. So if we didn't get to your question, Ian, if you can provide just email info in the chat for follow-up, because I'm fairly confident that I did not catch everything. I did my best to note them all, but there was a flurry of questions coming in. So Ian can help with any questions. And we're also, I think Diana would be more than happy to
Absolutely.
answer questions as well. Awesome. So there's a question here just around EHR support. How do you document for integrated visits? Does NextGen support combined documentation? If it doesn't, do you document multiple encounters for a visit?
Yeah, definitely. There's different ways for the different type of specialties. So, for example, our registered nurse has a specific encounter description with their template. That way I can pull information if I wanted to specifically say with the next gen, because we use next gen as well. How many visits have they serviced? So I can pull it based on the encounter description. For the registered nurse, for the registered dietitian and behavioral health, which are more of that billable visit, we do again have their own template, their own description for the visit, and then based on the billing requirements, we can link those visits to the medical services.
Awesome. Well, thanks. Diana, we'll do a virtual round of applause here for you. You've been awesome, and thanks so much for taking all of the questions here.
Absolutely. I appreciate you guys giving me this opportunity, and I look forward to that whole integration expansion across the board, because I really feel that this is valuable to our patient care and their needs, and really eliminating those barriers to care. So I'm excited to see how you guys can use some of this information and possibly try it at your site and see how that works for you.
Yeah, awesome. Just as a quick reminder, Ian just sent the chat for next webinar. So for Q2, it'll be May 11th at noon. We'll be talking about very similar, but more just a focus on dental, focus on how dental hygienists coming into a medical visit to provide some education can help drive similar results, especially with focus on pediatric patients. Thank you again. Thanks, Diana, so much. And thanks to everybody for joining today.